breast and endocrine cancer surgery, and has numerous published papers and textbook chapters in this subject. He chairs multiple medical professional councils and national level technical committees, and is actively involved as a policymaker in global organizations such as the WHO and the Drugs for Neglected Diseases Initiative. He is also a counselor at large in the executive board of the International Society of Surgery, the ISS, and chairs the Global Surgery Committee of ISS. In March 2020, he was elected as the chairman of the Asian Association of Endocrine Surgeons. Tan Sri Dr. Noor Hisham has been conferred numerous local and international awards, including the prestigious Fellowship ad hominem of the Royal College of Surgeons of Edinburgh in 2018 for his contributions towards healthcare. For his exemplary leadership in managing the healthcare sector's response in the COVID-19 pandemic, he was named the National Ma'al Hijrah Figure of 2020. Tan Sri Dr. Noor Hisham will share with us the nation's experience, strategies, and way forward in combating COVID-19 in his keynote address entitled COVID-19 Pandemic Response in Malaysia, A Journey Well Traveled.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a good day. First and foremost, I would like to thank the Ministry of Defense for giving me this opportunity to share the COVID-19 pandemic response in Malaysia, and a journey well traveled so far. We hope to end this journey as soon as possible if we have the vaccine, or even if we can have other measures to contain the infection. Next slide, please. Now, over the last couple of months, we have been stepping up our preparation as well as our fight against COVID-19. And to date, confirmed cases globally is 106 million. And in Malaysia, we had 248,000 cases been reported. Death rate globally is 2.3 million, and our census in Malaysia is 909. So the first case in Wuhan was detected late in 2019. We have our first case on the 25th of January 2020. And since then, we have 3 waves. The first wave started from 25th of January until 16th of February 2020. And then we have 11 days without cases, and we started our second wave on the 27th of February onwards, and until 16th of July, and that was our second wave. Then we have a period of 2 months without cases, our minimal cases, single digits and lower double digit. And when it came on to 20th of September, we started having our third wave following the by-election in Sabah, and that's where I think cases, our very challenging third wave, and although we are more prepared than before, but the third wave is more challenging than the second and the first wave. Next. And this is the slide showing the pandemic waves in Malaysia. Pre-pandemic, 0 cases so that is our benchmark at that point of time. Then when the first wave came on the 25th of January, when we have imported cases, we have 22 cases in the first wave, and mainly all related to tourists from China, directly or indirectly infecting the local. For example, 6 of our local individuals have been infected, and the genomic studies have shown that at that point of time, the virus comes from Wuhan, China. And then when we started our second wave, then we will be challenged by Sri Taling cluster, that is from the Jemaah Tabligh, and also the Immigration Detention Center. And then we see a change in terms of the virus here, because it's more towards a C strain that is coming from Indonesia. At that point of gathering in Sri Taling, we have 15,000 people gathered in this mosque, and 1,500 foreign participants, and 694 participants from Indonesia. Then when we started the second wave, we also have started our lockdown on the 18th of March, and it went on until July, 16th of July. And then our baseline at that point of time is no more, not zero, but we have calculated our baseline is lower double digit or single digit. So our average line of baseline is 25 cases. So until we reach on the 20th of September, then you can see the beginning of the third wave, which is more challenging, related to the clusters in Sabah, Kedah, Selangor, and also SOCSO foreign worker screening program. And some of cases are coming from detention centers and prisons. Next. So these are the pandemic waves in Malaysia. So if you can compare the first wave, second wave, we did well in the first wave and the second wave, and we managed to flatten the curve on the 14th of April 2020, following our MCO order on the 18th of March. It takes about 4 weeks before we can flatten. And because during that period of time, the festive season of Ramadan as well as Hari Raya is coming, so we continue another 2 weeks until May during our lockdown. And then we change our strategy because change our strategy from MCO to CMCO. The cost of MCO at the point of time, we were informed about 2.4 billion ringgit a day. So we have to change our strategy to CMCO, whereby to allow the economic sector to function, but to control the social education and sports sector. And we managed to contain the infection well following the CMCO until 9th of June. So we switched to the RMCO, Recovery and Movement Control Order. And this is important for us to resume back to all activities, social, economic, education, as well as sports. But they have to comply to the comply to the SOP. So we were doing quite well until August. We were seeing basically the RMCO two digits, lower 2 digits, even single digits, and we have a period of time 3 days we have 0 cases being documented. And at that point of time, I think it's important for us to have tightened the border control, but more importantly is the compliance and discipline to the SOP. And when we in March, in September, for example, during the campaign, political rallies and etc., the compliance and the discipline to the SOP were relaxed, and that's where we see the surge of cases following the Sabah state election. And now we are in a very challenging time to try our best again to flatten the curve. But during this period of time, I think it is also important for us to look back what we have done right and what we have not. And from the experience that we had, and because we need to balance between life and livelihood, so instead of going for MCO in Klang Valley, already we projected that there will be surge of cases in Klang Valley following the election in Sabah. But nonetheless, because of to balance health and economy, we decided to go for CMCO instead of MCO. And certainly, CMCO has managed to contain and even control the exponential surge, but we are not able to bring down the cases or even the R naught to less than 0.5. And I think, and that at that point of time, we also realized that we need to live with the virus. So we need to empower the public, to take responsibility to live side by side with the virus. And that's the reason why on the 7th of December, we ease the restriction in terms of interstate and inter-district travel. And although we were, Ministry of Health were not very keen to, ease the restriction, but we were hoping that the public will comply to the SOP. But when we ease the restriction, then there's a lot of activities of going back to their kampong, and also local domestic tourism, etc. And then we see a spike of cases following the decision in order to ease the restriction. Next. So the evolution of Malaysian SARS-CoV lineage analysis from the beginning, we are seeing the B Wuhan ancestral. Although we anticipated this, but now it's been substantiated with genomic studies. And later, the strip tiling cluster and immigration depot clusters, mainly for C-derived strain. And then following now, we are seeing clusters from Kedah, Johor, and Sabah and recent cluster with B derived. And also we managed to detect mutation. The mutation that we've seen in our country in Kedah, for example, the Siva Ganga cluster is D614G mutation, protein spike mutation. Then we had in Sabah, protein spike mutation of A701V, and subsequently now we realize that this mutation, spike protein mutation, has replaced the Wuhan ancestral strain circulating. About more than 100%, 100% of our current infection, they are all from the D614 strain and 70% from the A701V spike protein mutation. Next. So transition of a spike gene mutation, there's no persistent spike mutation that we see early outbreak during the strip tiling immigration depot. Then, as I mentioned earlier, the D614 came around from Siva Ganga, and also we have documented the D614 from Manila, from the cluster of Tampoi, and then the A701 mainly from the Benteng and post-Benteng clusters in Sabah. Next. Now, our approach in COVID-19, and then we look into a more holistic public and private integration of services. So the first most important approach, preparation that we did in 2018 in December is the preparation to diagnose our enemy. That is a virus. So we have enhanced our laboratory capacity. And once in China, they released the genomic sequence on the 3rd of January 2019. So we primed our lab and prepared the RT-PCR, working together closely with University Malaya hospitals, and came up with the RT-PCR testing. And we started training our staff in the lab, public sector and the private sector, working together, enhance our lab capacity. So we started with 23 labs with 23 laboratories with 1,000 RT-PCR capacity a day. And we continue to step up until today. We have 68 laboratories doing RT-PCR with a capacity of 76,000 cases a day. So that was the diagnostic component of it. And then we continue to do the public health interventions. And most important is evidence-based approach. Whatever we do have some experience from previous outbreak, for example, SARS, MERS-CoV, H1N1, etc. But this is unprecedented pandemic, the first time that we have experienced, and from a different magnitude and scale. So we also have Act in place, that is Act 342, and but it was actually meant for to contain a smaller scale of infection. But we have to use this Act to help us in terms of contain and the infection. So prevention and control protocols are all in place, treatment and clinical protocols, and all this experience, health technology assessment, all are based on evidence, current evidence, etc. So we have 5 strategic approach in terms of to combat this COVID-19. The first most important is border control. The international border, the interstate border, inter-district border. So we continue to do so. Second is that to look into a health system capacity and capabilities. So how to scale up our healthcare system, integrating the public and the private sector. Third is that we look into the public health response in terms of surveillance, the community, in terms of contact tracing, active case detection, targeted approach to mass testing, and doing the cleanup and mass screening of enhanced CMCO in certain localities. All these are important public health messages. For example, avoid the 3 Cs and practice the 3 Ws. And we have the CAPP and the RRP, that is Community Empowerment Program. And the fourth strategy is basically to protect the vulnerable population. Say, for example, looking into the Aborigines, Orang Asli, or the rural area, long houses, etc. Because our fear is that if the infection spread in this community and their immune system is not as strong as those who had the immunization, etc. So this is the challenge that we have. And the fifth, if you look into communication, strategic communication, and we must be transparent, factual, and consistent. So here we engage with the public, important engagement with the public daily to explain issues and challenges and to manage the public expectation. Hopefully that we can get trust from the public, looking in our data and as well as factual in terms of interpretation, etc. Last but not least is public empowerment. So we believe that, if the responsibility is on the shoulder of Ministry of Health alone, we would not succeed in terms of to contain or even to win this war. We need the whole government and whole public, whole society approach, whereby every individual is important to contain and to help us to fight this infection. So this is a whole approach that we have for COVID-19. And we were complemented by the movement control order that is, started during 18th of March 2020. We started our very tight movement control order. But at that point of time, there was a lot of unknown to us in terms of the virus and whether our approach is right, and learning from other countries. So we were perhaps overdoing it a bit. For example, looking into the state of Sarawak and Perlis, there are no cases, but we still impose on them the movement control order. So now we are more targeted in terms of approach in certain districts, in certain states to contain the infection. Next. So the Malaysian preparedness and planning began since December 2019. So before we had our first infection documented on the 25th of January, so the CPRC team, the Health Ministry, ramping up our border screening over the China influenza outbreak, and also we started to have our guidelines to prepare our staff in terms and our facilities and how best we can integrate the public and the private sector coming together. And we believe that coming together, we can make the impossible possible. And although we are living in a very challenging times, and working as a team, the unity is a key for us to break this chain of infection. And we need to strike a right balance between life and livelihood. And certainly loss of balance means loss of lives and also loss of livelihood. So our strategy is to impose on the short-term pain and the long-term gain. And this is why we do not see any reason for us to extend the MCO longer. So we just need a short MCO, 2 weeks or 4 weeks maximum, and to contain the infection, and then we back to CMCO or RMCO, but provided the public must comply to the SOP. Next. And the Ministry of Health Crisis Preparedness and Response Centers are very important centers that we have actually developed this over the years from our past experience of managing other communicable diseases. And we have a national CPRC. We started activating this CPRC on 23rd of January 2020. And we have a command control coordination center. And we also coordinate with the hospital services CPRC and the state CPRC and hospital operation room. So we do have a network in terms of how to manage this pandemic response in our country. Next. The targeted approach mass testing has been adopted since day one, or in other words, a selective mass testing. So we have 3 areas that we're looking to. First is a surveillance screening. This has been ongoing for many months. Sentinel influenza-like illness and a severe acute respiratory infection in our hospital. Healthcare worker screening periodically we are doing, and the latest was the pre-operation screening, because I think it's very important for us to screen every patient before we do the surgery. And other screenings that are in place is person under investigation screening, close contact screening, community screening, symptomatic screening, ward and hospital admission screening, pre-employment screening, workplace screening, self-screening, or even BID, brought in dead cases. We also screen before post-mortem done, and arrival on high-risk area and screening has been done as well. So we also focus on the targeted group, basically the large street tiling cluster, and in certain schools, for example, Tafiz and Madrasah screening, the Ministry of Health Healthcare Worker Screening Program, and we enhance the CMCO screening. If we CMCO an area, so everyone, regardless of local or foreign, will be screened. And travelers, the import all cases coming back, Malaysian returnees, for example, and those coming to Malaysia will be screened at our international gate. And also, we also focus on certain cluster in markets, and foreign worker screening in the red zone area, foreign worker screening under the SOCSO program, elderly care centers, plus the retention centers screening program. So these are some of our screening. To date, we have done more than 5.297 million individuals have been screened as of 9 of February 2021. Next. Our hospital preparedness for COVID-19, we have 4 phases. We started with the alert phase, that is in January 2020. Later, we went on to early containment, and now that we are in the late containment and also perhaps a mitigation phase, that's the emergency phase. So we went through one strategy to another, how best we can adapt, and then to fight this war against COVID-19 in our country. Next. And to date that we have changed our strategy because of the increase of number of cases. We are not able to contain and to admit all cases, positive cases, category 1 and 2 in our quarantine center or even the hospital. So we have started category 1 and 2 to be isolated at home. So, we have established this COVID assessment center. All positive cases will have to be placed and assessed in this center before we decide the high risk group and low risk group. Those high risk group will be placed in quarantine center, but those low risk group, perhaps we can consider to be isolated at home, provided that they have a suitable home that they can isolate themselves well. And they need to upload our MySejahtera apps program for home monitoring. And these are for category 1 and 2. So every day we will monitor them from 9 o'clock until 12 o'clock to get all the information from them in terms of the symptom progress and etc. So at 12 noon, the information will be analyzed and then sent to the PKRC. And we do have also established a unified command center whereby we look into the wards as well, the beds in the ward as well as the ICU beds, integrating the private hospital, the Ministry of Health hospital, the University and Army hospital, and in terms of how best to manage, maximize utilization of our resources, and to know which hospitals or beds available and ICU beds are available. Thereby, we can actually utilize the beds and optimize it as best as we could. Next. So this is a COVID-19 assessment center, the flow. You can see it very well that how we can monitor and how we can refer a certain patient to the hospital or even a quarantine center if needed be. And most important is that, to step up our monitoring at home, for example. So the objective of this center is to identify patients who are suitable to be monitored at home, to be monitored and access patient at home using standardized tool that has been established to identify and access patient with disease progression, as well as to coordinate referral from health clinics to the quarantine center or hospital. Next. Okay, now we are looking into the SEER model of COVID-19 daily observed and forecast cases from 12 September 2020 to 31st May 2021. So basically, we're trying to capture the progress of the third wave. So as of 9 of February, that's yesterday, the estimated RT or R naught for Malaysia is 0.91. So you can see that initially we started with the R naught of 2.2 on the 20th of September. So in the implementation of CMCO, we managed to bring it down to between 1.2 and 1.1. We were not able to bring it down further. So and during the third phase, third wave is certainly very challenging as compared to the second wave. But nonetheless, we are more prepared than the second wave because we know more about the virus and how best to handle, to manage this virus. So on the then we started the PKP or MCO on the 13th of January. So we expected 2 weeks there will be to prevent the surge of exponential surge of cases. The next 2 weeks, the fourth week is to plateauing the graph, graph as well as probably see a downward trend. So on the 31st of January, we saw a peak that is 5,298 cases. As you can see here, the forecast is much higher, the projection much higher than the R naught or RT of 1.2. So last 9 days, we continue to see the plateauing and also decreasing numbers of cases. And we hope that this trend will continue. So far today is 0.91 for the last 2 days, yesterday's and day before yesterday's. The RT is 0.91. Next. Now, so this is the trending of the R naught that or RT that we have seen from the 1st of January, and then you can see that the peak was on the 31st of January, of which the RT was 1.16 with 5,298 cases, and then we see some good progress of declining R naught RT status to 0.91. Still not good enough. Our target is to achieve at least 0.6 or 0.5. Then we can rest assured that every 1,000 cases, the next cycle will have 500 cases, and the next cycle, 7 days, we will have probably 250 cases and so forth. Next. So this is the daily cases, 7 days moving average in Malaysia. So you can see that the projection, the forecast of RT or R naught 1.2 and 1.1. And the implementation of the 4-week MCO followed by CMCO from 13 January to 9 February, and then we have extended now because of the Chinese New Year. It's going to be certainly a make or break situation. Because of that, we have extended to 18th of February after the Chinese New Year. So we hope that we can bring down the RT from 1.1 to at least 0.6. So we can see the peak highest average 7-day moving average was on the 31st of January, and now we are seeing the trend of declining trend. So hopefully that this will continue. Although you can look into the red zone, although our projection is cases are much less, peak of about 2,700, but in reality, we are seeing 5,000 cases, but during the same period of time. So we hope that the numbers are high, but the projection, same period of time, is responding to our projection and trajectory. So we hope that next couple of weeks we can actually bring down or the whole cases towards a downward trend. Next. And the cases among Malaysian citizens, initially when we started in October, non-citizen foreign workers, much higher in terms if compared to the local. 65% foreign workers, and then local about 35%. But today things have changed. Look into the citizens, much higher, about 70%, and the non-citizen foreign workers about 30%. Next. And the sporadic cases also have increased. Initially, mainly we are seeing cluster cases during the second wave, but here during the third wave, cluster cases are less. 70% of the cases we see sporadic, which means that the virus is already in our community. Whether we like it or not, we have to live with the virus and to take precaution, public health measures in terms of to avoid prevent being infected. Next. So, and our screening surveillance positive rate, but weekly, you can see that there's increased number of ID cases, SARI cases, pre-operative cases, and etc. So, this is certainly a very challenging period of time because the virus is already in our community. We are not in the attacking mode, but we are in the defensive mode now. So the only key to success is to comply and have a high self-discipline in terms of to comply to all our SOPs. Next. So increasing number of patients also have been admitted to our ICU and hospital. You can see in our ICU, for example, the cases has increased from September onwards, and we have more patients being ventilated and also non-ventilated patient placed in ICU. Next. So looking into our mortality until 9th of February, 87% of the mortality that we had are Malaysians, and then 38% comes from Sabah, and 65% mainly male, and 84% those who have succumbed aged more than 50 years, and 87% have at least one comorbidities, diabetes or hypertension, and we have 22%, 202 cases been brought in death, BID to our hospital. 87%, 615 cases are presented at stage 4 and 5. Next. So we look into the census in 2001, total of 372 patients died in our hospital, and total of 66 are brought in death. And you can look into the numbers. Total death in 2020 is 401 cases, and to date, we are coming to second month, that is February. We already have 438 fatalities. So this is a concern to us, and perhaps we are looking into a more severe form of infection in the community, and basically we need to protect the vulnerable population. Next. So the COVID-19 dichotomy is balancing the economy versus health. So we are in a shared struggle to protect both life and livelihood. This is not easy. In every meeting that we have, we need to strike this balance. And it's not easy to strike the right balance between health and economy, between life and livelihood. And I would say loss of balance means loss of life and loss of livelihood. Next. So finding the optimum balance between health control, COVID cases, and economic livelihood, what is possible? So if we were to look into the lockdown on the extreme right, then you can see the impact on economic outcomes. But certainly the lockdown for 2 weeks and 4 weeks, we can see the impact in a controlled environment, less cases. On the other hand, if we follow the herd immunity approach, or even manage our economy well, but if the cases goes up, the economy will goes down. Again, the impact will cost us in terms of life and livelihood. So if we were to strike the right balance in terms of economy and health, then it will take the duration, the time. So unless we do it in terms using the MCO, tighter, stringent, tougher measures put in place, then our economy will recover fast. So our principle is a short-term pain and a long-term gain in terms of economic growth, rather than moving towards uncontrolled cases and spread of COVID-19 in the community, and the economic goes down as well. So that is the worst scenario on your left. Next. So the National COVID Immunization Program, so that's how we have done what we did to do best, that is actually using the MCO for 4 weeks, and then after 18 probably will revert back to the CMCO, that, and hopefully we'll see a downward trend as shown earlier. And our second strategy depends on the immunization program. So hopefully by the end of this month, we will get our vaccine, and we'll start with phase 1 for all frontliners, phase 2 about 9.3 million for those vulnerable population, phase 3 is for adults 18 and above, phase 4 is mainly that we look into vulnerable population that we need to vaccinate. Next. So that's about all from me, and I hope that this is just a summarize. This presentation summarized our journey over the more than 1 year, and certainly this is a marathon for all of us. But more importantly, we have to come together, working as a team, see how best we can move forward. And I'm sure all our frontliners having experienced fatigue mentally and physically, but the war is not over yet. The virus is still very active and mutating. So the challenges ahead, we need to re-strategize, hoping that our public health measures as well as the vaccination will work in time. And we hope that we can contain and even end and win this war in a short period of time, probably end of this year or even next year. And certainly this is a long journey for all of us. We hope to see some light at the end of the tunnel. So this is coming together and survival of the fittest, working together to make a big difference in our healthcare in our country. Thank you very much.